Okay, hi folks, it's Andrea. I'm your facilitator for this week's COVID Echo Long-Term Care. And we have two speakers today who are going to speak on rewiring our approach to safety. So Virginia's joining us from Toronto and Anne is joining us from the lovely Prince Edward Island. So welcome both of you, and you're good to go.
So our first couple of slides are just our standard disclosures, and essentially Virginia and I have absolutely nothing to disclose. We are both staff at the Canadian Patient Safety Institute. We're both senior program managers, and we've both been with CPSI, myself 12 years, and Virginia, I think you must be 13, 14, 15, since the start. Yeah. So we're going to talk to you today about rewiring your approach to patient safety. And not just patient safety, but safety in general. To begin, I just want to start by thanking you for your commitment, dedication, compassion while providing patient care to your residents. We really appreciate the sacrifices you've made and continue to make during this COVID pandemic. To get started, I just want to get a sense of how everybody is feeling. It's been quite an unprecedented few months, and I just want to get a sense of how everyone on the line is doing. I haven't had the privilege of really having much opportunity to connect with people who are providing care, so this would be very helpful to myself and Virginia to have a sense of where everybody's at right now. So I threw up a couple of feelings on the screen there. Maybe if you could just take a second and throw in the chat box some comments around how you are feeling. And if how you're feeling's not on the screen, by all means, just express how things are going. Tired but optimistic. I see some stressed, motivated and resilient. That's great to see. Stressed, optimistic. It's nice to see some optimism. And what really, Virginia and I are hoping that we can help extend that optimism during today's call. We hope that we're able to share a little bit of our passion that we have for safety with you guys. So because we work for the Canadian Patient Safety Institute, you will probably get a sense that the majority of our presentation will speak to patient safety, but we do recognize that staff safety is just as important. And we recognize that to take care of others, you really do have to take care of yourself. And I just wanted to share with you a couple of resources that we have at the Canadian Patient Safety Institute. And if you're interested in learning more, we can always connect you with my colleagues that run these particular programs. So one of our resources we have is creating a safe space, addressing the psychological safety of healthcare workers. And going along with this document is we're developing a peer-to-peer support program. So if this is something people are interested in and want more information, we can definitely help connect you with the right people and the right resources. And the other resource that I think might be of interest to you is the Team Steps Canada. And this is a program geared towards enhancing teamwork and communication. And the excellent news with this is that we're going to be launching a virtual Team Steps program, and this will be free and open in both English and French. And it should be coming fairly early in July. So another resource that you can keep your eyes and ears peeled for. So now moving on to the main portion of our presentation, which is around patient safety. And just a quick little history lesson. Patient safety in Canada really got launched with the release of the Canadian Adverse Event Study. And we are privileged to have one of those authors of this precedented research article with us. Virginia Flintoff was one of the authors. And what this research showed us is that 7.5% of acute care admissions are associated with an adverse event. And of those adverse events, we determined that close to 40% of them were preventable. We know inside healthcare that unnecessary and unintended harm comes to patients, whether they're receiving care in acute care, long-term care, home care, or primary care. And so with the release of this study, then became the launch of the Canadian Patient Safety Institute and then our Safer Healthcare Now program. And Safer Healthcare Now was really geared towards providing clinicians with the evidence and helping through a step-by-step process, helping people implement that evidence. And, you know, this idea of giving good people with good intentions, good evidence, and the means to do it, we thought that we would move the mark on patient safety. And while we did have some success and some gains, here we are 15 years later, and we really haven't moved the mark substantially on patient safety. So we're still trying to navigate our way and find that the means to help reduce unnecessary harm in our health system. And what we came across was quite fascinating and quite remarkable, and we are starting to see some substantial gains. And that's what we hope to share with you today, this broader view of safety. So on the screen, you see a question. How safe is your care? And this is a question that we believe everybody should wrestle with. We know there's no simple answer. And I just want you to take a moment and pause and reflect. If you have a pen and paper in front of you, just write down a couple of little notes in terms of how you would answer this question. What comes to mind when someone asks you, how safe is your care? There's no right or wrong answer, just really kind of what's on top of mind. And maybe when we come back to our dialogue and conversation after our presentation, people will be willing to share some of the thoughts and ideas that they jotted down. So a few years ago, Charles Vincent, who was a global leader in patient safety, was approached by the National Health Services in the UK to help answer this question, how safe is our care? And through conversations with him, he had told us he was quite keen to answer that question. It's a very important question and one that people want to have an answer to. But once he set in to do it, he determined he couldn't answer the question in terms of how safe care is in the UK. Because unfortunately, inside healthcare, we have a bit of tunnel vision. And we define safety through harm. And what he's come to teach us is that patient safety or safety in general is more than counting harm. And I went to long-term care sites in Ontario, and here's how patient safety is defined inside Ontario long-term care. Through these indicators, through counting different types of harm, whether it's falls or pressure injuries, pain, depression. But what we're here to tell you today is that the absence of harm is not the same as the presence of safety. And what we're here to tell you today is that there are things that you can do to help create safety over and above and beyond just preventing harm. Another question that I want you to pause and think on is measures of harm. Did they tell you how safe your care is or how lucky you've been? And I see some people smirking and nodding their head. And how often have you been looking through incident reports? I know as a previous risk manager, I would be looking through risk reports and I'm like, man, we're lucky this didn't happen sooner, or man, we're lucky we didn't have this happen before to more people. So another thing to think on, and maybe we can have a conversation about this as we begin our dialogue in a little bit. So when we look at this broader view of safety and really the power of inquiry, we now can come up with a broader definition of what safety really is. And Charles Vincent told us that there's really 5 dimensions. And harm, it's where we spend the majority of our time, is really only a small piece of this. And the other thing he taught us is the power of inquiry, which is something that is quite often missing inside healthcare and something that he saw in other industries, that there's great power in inquiry. So what he was wise enough to do was, through these 5 dimensions, attach a question to each one of these. And so what I hope to do in the next couple of minutes is quickly go through each one of these dimensions to just give you a glimpse into what each of these 5 dimensions are. So the first one, has care been safe in the past? And we see this is very much a rear view mirror approach. And what we know is that measures, things that have happened in the past don't always necessarily predict what's going to happen in the future. And we know that just the mere counting of harm in the past does not translate into change into the future. It requires more. We know that this indicator of harm is very important, but alone, it's not enough. And even when we look at harm, we know we have a fairly narrow view of what harm is. But what we have learned through doing this work is that we can widen our view of harm. And we were able, with some of the teams that we've been working with, come up with 8 different components or types of harm. And I'm sure there's others out there. But on the screen, we have physical harm, psychological harm, harm that occurs during the transitions of care, harm that occurs from overtreatment, undertreatment, delayed or inadequate diagnosis, dehumanization, and hospital-associated functional decline. And so with that, we're going to pause and go to our first poll of the day. And that poll is, what I want you to do is to rank the types of harm in the order in which you pay attention to them in your work. So no surprise that we see physical harms at the top of the list. And that is, not uncommon, what we normally see when we ask this particular question. Dehumanization is an interesting one, and while people are completing that poll, I have a nice little story to tell you about dehumanization and how easy it is to actually start to shift and work towards reducing dehumanization. So one of the teams that Virginia and I worked with was a long-term care home in Saskatchewan, and the leader of that home recognized dehumanization was a concern inside their facility. And so at a manager's meeting, she asked the managers to list 3 words that they commonly use inside their facility that could lead to dehumanization. And the managers came up with the 3 words, and then together they came up with 3 new words that they could use to replace those. And the one that I recall was the common use of diapers, and recognizing that other people would not appreciate hearing of their loved ones having their diaper changed. And so they collectively agreed that they would stop using that term and shift it over to referring to them as adult briefs. And you could hear that shift in the language when Virginia and I were there visiting the home. It was a quick 3-minute exercise that they did at a meeting, but it made a substantial difference. And that leader of that home then challenged the managers to go back to their unit and have that same conversation with their staff, and have the staff identify words that they would like to shift and change. And that's what they did. Okay, well, thanks for participating in that exercise, and we'll carry on. So the next dimension is, are our clinical systems and processes reliable? And so this is really gauging the probability that a task or process or intervention will be carried out as it's supposed to be. And so we like to use this little example of what would happen if we had systems of only measuring the number of people that fell through the ice rather than measuring the thickness of the ice. And so how often inside healthcare do we get so focused on measuring harms and we forget about all of the important processes and steps that go into preventing very specific types of harm, and how important it is to have consistent standard ways of working through different types of processes and systems. So our next dimension, and as we've been working with people, we hear this is the dimension that resonates most with people that are hands-on delivering care. And the question is care safe today? And this is really the hearing, seeing, perceiving, learning, and communicating, and acting on the information you're gathering. And the really important feature of this dimension is the today portion, the moment by moment, minute by minute, day by day interactions that are really important in creating safety. Not something that gets filled in and report and escalated up and then brought back down again. It's acting on the information you're collecting moment to moment. The next dimension is, will care be safe in the future? And this is really the message around, don't wait for things to go wrong before trying to improve safety. Sometimes we see things and we go, I don't know. But I tend to go, oh, it will be okay, rather than taking that information and collectively acting on it to help create safety. And the last dimension is, are we responding and improving? And this is really taking the learning, sharing, and responding based on the intelligence and the insights you've gathered through asking the other critical questions. And together you put all of those pieces together in order to create safety. So just as you can take 5 strands of thread and weave them together to make a friendship bracelet, what we've learned is that if you take these 5 dimensions of safety and you weave them together, you can really create a culture of safety. And as I've mentioned, Virginia and I have been working with teams over the last 3 years on helping organizations and teams actually create safety. And these are some of the tips and ideas that we have learned from them. Number 1, you don't need money. You don't need more resources. You don't need consultants. You have the people. And what you need to do is to talk to each other, engage each other in safety conversations, and engage in others with collective solutions. There's always something that can change, even without resources. And through all of this, positive change can occur. So with that, I'm going to turn things over to Virginia, and we have a few photos and images that can hopefully help translate how teams across the country have been working hard to create safety.
Hi, thanks, Anne. So what I want to share with you today are strategies, tips, and tools that were developed over the past 4 years by the teams that worked with Anne and me and Wayne Miller from CPSI on measurement and monitoring safety. I have to say at the beginning, we had gone to learn from the team in the UK about this new and really dynamic model of safety, and came back, and Canada is setting the pace now. We are ahead of virtually every country in the world in this. So I'm going to start by introducing you to the Safety Huddle board. This was developed by St. Joe's. It was without the St. Joe's in Toronto, it was without a doubt the most successful tool that has been captured by all of the teams and used and spread throughout their organizations. It's been tweaked, but it has been a really successful model for them. And what this is, I'm showing you their prototype board, Huddle board, which is they started with the lean quality board and then pasted over it the measurement and monitoring of safety. You can see the 5 domains at the top in red. And what they did on this birthing center was on the left, you can see in a very rough package, they've put empty safety cards so that if the staff member, regardless of who they were, maintenance up to senior leaders, saw something that they wanted to discuss, they take a safety card, complete it, and place it under new ideas where the green label is. Then every 3 times a week, they'd spend an hour at the nursing desk looking at this board and to discuss each of the safety issues. The first step they do as they discuss, they present the issue, then I do using a pick chart, they establish what the impact of this safety issue might be, high or low, and the ease of implementation, again, high or low. Once they've decided that, then they make a decision on how, when and how to implement it. Many of these were just do it. You don't need to ask permission. You don't need to get approval. You don't need money. You just do it. A quick example was on this birthing unit, they had equipment cleaning wipes like Lysol wipes in packages in each of the rooms, and some of the parents were using them as baby wipes. So the idea was take that out of the room. You don't need the CEO to approve that. That's a just do it. The next is are those issues that need to have funding. They need, they're bigger issues, painting things, buying new equipment, whatever. That goes in your longer term problem solving and are addressed every week or every meeting to just update on how the progress is on how you're going with that. That takes us to our completed section where the items, when they have been resolved, are pasted there, addressed to the staff, and then put into a log so that it's maintained. And finally is the celebration. And this is where at St. Joe's they would put letters of thanks and things like that, and just review them with the staff so everybody got a pat in the back. But what I loved was, as I said, this model has been tweaked by other teams, and William Osler took this model and they turned it around, and they start with the celebrations. So at each of their huddles, which is daily, they ask the staff, do you want to say anything about one of your colleagues that did something great? And it really was very moving to see this happen. And in fact, patients and relatives came in and said, I want to add to the celebration part. The other thing that St. Joe's did was they had yellow Postits for patients and their families to post safety concerns or anything they wanted to share. And that was on a board to the left of the safety board. This is an infographic that was developed by a team in Southern Alberta. And what they did was take the 5 domains from past harm, reliability, sensitivity to operations, anticipation, preparedness, integration, and learning, and applied it to a safety strategy for walking on icy roads to work for the staff. And it made it really transparent for the staff to understand what these different dimensions were, because they understood past harm and reliability, but once you got into sensitivity to operations, anticipation and preparedness, and integration and learning, it was a bigger leap for them. Observation. This is a strategy that we use in every organization that we coach, where we ask teams to go in groups of 2 and go to another floor or on your own unit and just walk around and identify issues that may not be safe. And what you see here is a key in the medication drawer. You see on the right, you see the staff only door wide open, and anybody can walk in there and take anything they want. And the middle one was one that Anne and I enjoyed the most. It was the maintenance cart with the drill on top of it, just left unattended, and it was right outside the door of a resident who was designated as highly violent. And they just were oblivious to this. So it's best if you send people, you get people to come up who aren't used to looking at your own unit, because you become a little blind. This is the Truth or Dare booth, which was developed by a team in Northern Alberta. And what they did was rig up a walker, called it the Truth or Dare booth, where people could go and write down some items that they were worried about in terms of their safety on their unit. But it gave them the ability to voice their concerns without having to speak it out loud or create what they may perceive to be problems. We also had a visit in a long-term care facility, and we met with some residents, a panel, and one of the exercises we asked them to do was to take this paper and write the answer to the question that's in the top left-hand corner that says, what makes you feel safe? And these two wonderful gentlemen wrote down what made them feel safe. But after you ask them what makes you feel safe, to go a little deeper into this, you might ask them, what could make you feel safer? So it's not making you feel safe right now, but let's get a little bit into those issues that worry you. So this is the maturity matrix. It was originally developed by Dr. Jane Carthy, who's one of the authors of the original Measurement, Monitoring, Safety Framework. Ross Baker and I took the UK model and made it more Canadian friendly. What you see on the rows represent each of the 5 domains, and the columns are what level you believe that you're functioning at, from the lowest level 1 to the highest level 5. And we would ask the teams to score themselves for each domain. And we found that not only is this a good way of monitoring your progress, it's very interesting to see the difference between different levels of professionals. So in one of our first programs, we found that the frontline staff scored the team or the unit much lower than the physicians and the senior levels. That doesn't make either of them wrong. It just says people see different things in safety, and our goal is to bring them together, to communicate, bring them together, and move forward. This was an example of a really lovely tool that was developed by a team that was in our most recent collaborative, and it's a Monopoly game where each step is a step on improving safety and quality. Your pieces were little cars that aren't shown there, and you roll the dice and work your way around, and you come back to your start. And when you get back to start, you lift up the start flap and it says, keep going. It's terrific. Yep, this is a great one that you can see when you get these slides, developed by Interior Health, and it's the 4 outside domains that all feed into integration and learning, and they are metrics for each one of them. Anne, over to you.
Okay.
Oh.
So I think, you know, you have these slides, and really take a moment to look through some of the key learnings. I think we've touched on quite a few of these, but I'd say probably couple of the most important ones that we've learned through this is that collective responsibility for safety that comes through having those conversations and together collectively coming up with solutions. And the other piece is the value that patients and caregivers can have in creating safety. And those come through conversations with your patients and your residents and your families around what safety means to them. And everybody can contribute to safe care. It's not just staff's responsibility. It is a collective responsibility, and everybody wants that ability to contribute to that. We do have a quote, which I will leave for you to read. And then our last slide is the shift in thinking and a shift in approach. And what we've learned is that safety can be hard to see, but we can learn to look for it. And more importantly, we can learn to create it. And so I'm going to leave you with a couple of questions. What can you do to bring safety into focus? And how can you shift your approach to create safety?